What is an umbilical hernia? What is a ventral hernia? How do you diagnose them and make the decision to treat these? We're going to be talking all things umbilicus, ventral hernia, umbilical hernia, all of that today at Citizen Surgeon. Let's do it. Welcome back to Citizen Surgeon. My name's Dr. Erik Pearson. I'm a pediatric surgeon, and today we are right in the strike zone, pediatric surgery, talking about umbilical hernias. I'm going to be talking about ventral hernias, how they differ a little bit, but include umbilical hernias. I'm also going to be talking about the development of the umbilicus and all of the important structures that you need to know there. All right, so hang on. This is an important topic. It comes up every day as a pediatric surgeon. In fact, today in my clinic, I saw 3 new patients with umbilical hernias and had to decide, is this necessary to fix right now for this child, or can I provide the parents some reassurance that an operation isn't necessary yet or ever? Okay, so we're going to talk about that today. Let's get into it. So a baby's born, and this is what you see, a little bulge at the umbilicus. Well, what is that? Well, almost everybody could tell you that this is an umbilical hernia. Well, what do those words mean? What is a hernia? Well, a hernia is a protrusion of an organ or tissue through the barrier that contains it. I don't like to think about it as in a weakness in the fascial layer because, for example, an inguinal hernia, if we have a direct inguinal hernia, and we're going to get to that in future videos, but a direct inguinal hernia is just the continuation of a congenital structure, that tunnel from the peritoneal cavity into the scrotum or into the labia. And when that tunnel doesn't close off, you have an inguinal hernia. Now, that's not necessarily a weakness, that's just persistence of a congenital structure. So I like to think about hernias and define them as the protrusion of bowel or tissue through the barrier which contains it. I also want to remind you, if you do like this content and you want to support the channel, make sure to subscribe, turn on notifications, share it with your friends, and of course, engage. Leave comments. If you have questions from today's video, throw them down there and I will get back to you. I love engaging with you guys. I also want to put a note in, check out the description in these videos. I'm going to put all the references in there. I'm going to put some important books or textbooks you should be looking at. And I'm also going to direct you to the pages at CITIZENSURGEON.com where I'm going to have more information like the 4 important takeaways from the video today and some notes that accompanies it. And this is all free stuff, so be sure to check that out. Getting back to hernias, we have this little baby right here, okay? And you can see they have a ventral hernia or an umbilical hernia. When we take that in cross-section, we can see that the bowel is protruding through the barrier of the anterior abdominal wall. That's why we call it a hernia, okay? And you can see the layers. We have the skin, we have the fat, we have the muscle, we have the hernia sac, and then of course that protruding bowel. But what is, if we want to define it, what is a ventral hernia? Well, a ventral hernia is a defect in the abdominal wall that allows an organ or tissue, usually preperitoneal fat, to protrude through it, and that can occur anywhere in the midline of the anterior abdominal wall. So anywhere from the xiphisternum to the pubis, okay? Now, can you see the ventral hernia in this image of a little boy's abdomen? So right here, the blue circle pointed out. Now this is right in the midline, sometimes a little to the left, sometimes a little to the right. And this will usually present as a bulge right in the midline, anywhere from xiphisternum and pubis, but usually between the umbilicus and the xiphisternum. But let me ask you this question now. So what is an umbilical hernia? Well, an umbilical hernia is the protrusion, usually intestine. That's why when you reduce them or you squeeze them, you'll hear that squishy sound, okay? So protrusion of bowel, sometimes fat or omentum, through a defect in the fascia which failed to close at birth. And you can see 2 examples here. So you can see in this baby, there is an umbilical hernia, a little bit larger, and this is definitely protruding intestine. And in this other baby right here, you can see that this is a little bit more subtle, but certainly an umbilical hernia is present. Now, if we're gonna really understand umbilical hernias. And if you've watched these videos before, you know that I like to get you to understand things. We need to go back to the embryology and understand the umbilicus. So what is the umbilicus? All right, so we see this embryological image here. This is when the fetus begins, the embryo starts to get into its flexion, okay? And when we zoom in and we focus here, we're checking out the umbilical cord. Now, when does the umbilical cord develop? Well, this is really between the 4th and 8th week of gestation. So at that time, remember, we have our yolk sac. It's divided into intracoelomic and extracoelomic cavities. The body stalk has now given off the allantois. That's going to be part of the urinary system. And then over these weeks, we're going to have the vitelline vessels, the umbilical cord vessels, as well as the omphallomesenteric duct are going to be included in this connecting stalk, which is the umbilical cord. Okay, so what does the umbilical cord contain? Well, normally it's going to contain 2 umbilical arteries, 1 umbilical vein, the omphallomesenteric duct, or the vitelline duct. At this early stage, it'll also include the allantois, which is connected to the urinary system via the urachus, and also Wharton's jelly, which is really that expanding amnion and mesoderm, which is holding all of these structures together. Okay, and that's going to form the umbilical cord. Now, after birth, we no longer need the umbilical cord because we're no longer on placental support. And so the umbilical cord is divided, and eventually after a few days, it releases from the umbilicus, and we're left with a picture that looks a little like this, okay? So remember that there are 60 different types of umbilicus, okay? So, well, what is the plural to umbilicus? Umbilici, maybe? So 60 different types of a belly button. How about that? All right. And so when we look, well, what's the normal position? So the normal position should be in the midline at the level of the iliac crest. Well, why is that important? Part of that importance comes, so for me as a pediatric surgeon, if, for example, I have a child that's born with an abdominal wall defect like an omphalocele or a gastroschisis, and I have to rebuild the umbilicus, I'm going to want to make sure that I get it in the midline at the level of the iliac crest as a general rule. But the important thing here is all umbilici or all belly buttons may look a little bit different. Okay, well, what are the important structures at the umbilicus? Well, I've outlined that here. You have the umbilical vein, which is going to be going superiorly, a single umbilical vein. We'll talk about why that is important here in a minute. You have 2 umbilical arteries normally, okay? And those become the medial umbilical ligaments, all right? And then you can have the urachus, which is going to be inferiorly, okay? And you would know if you had a patent urachus, so this is the connection between the umbilicus and the urinary system, if after birth there was urine coming from the umbilicus, all right? Now, it may be scary to think about, but what if stool was coming from the umbilicus? Well, if that's the case, then you have a patent omphallomesenteric duct, which is that connection between the umbilicus and the intestine, usually the terminal ileum, where you would find a Meckel's diverticulum, okay? So if you have poop coming from the umbilicus, you have a patent omphallomesenteric duct. If you have urine coming from the umbilicus, you can have a patent urachus. And then the other structures that are important are that single umbilical vein and the 2 umbilical arteries, which become ligament of teres for the umbilical vein, and of course the medial umbilical ligaments for the umbilical arteries. Now, getting back to that question, why is that important? Why is the position of the umbilical vein important to know? Well, number one, as a pediatric surgeon, if I'm doing an exploratory laparotomy on a baby, remember that that umbilical vein is still patent. So I may come across that if I'm doing a transverse incision in the abdomen. I'll have to ligate that vessel to prevent any bleeding. Number 2 is in a baby, we may have an umbilical catheter or an umbilical catheter providing IV nutrition or IV fluid to that baby. And I have to make sure if I'm doing an exploratory laparotomy that I don't divide or come across that catheter. That might be life-saving vascular access. A third reason knowledge of this anatomy is important is because in laparoscopic access in a baby, a trocar or a VRS needle can be placed in that umbilical vein. If that umbilical vein is accessed and insufflated, then gas can go into the heart instead of into the peritoneal cavity, and that can create a very serious, almost deadly situation for that baby. So knowledge of this umbilical anatomy is very important. I will say one more thing, maybe a fourth thing related to that umbilical vein is, what's the name if you have an adult who has liver disease and comes in with portal hypertension and they have increased collateral circulation? What do you call that when the umbilical vein distends with blood and you can see it around the umbilicus? Well, we call that caput medusae. Okay, so a fourth reason it's important to know this anatomy. So let's dive into umbilical hernias. What is the epidemiology? Well, how frequent, how common are these? Well, about 10% to 30% of children are born with an umbilical hernia. It is the most common hernia found in children, and it is an equal incidence in boys and girls. You should know that we'll see this in increased frequency in babies or children that have African heritage and babies that are premature, and inherited trisomies, so trisomy 13, 18, 21, and some other inherited syndromes, and I'll put those in the description below. Well, how do these kids present? Usually, these children will present to their pediatrician with an asymptomatic bulge at the umbilicus, okay? That is how we diagnose an umbilical hernia. Now, you should know that incarceration or strangulation of these are extremely rare in children. It has been reported, and it certainly is a risk of observing umbilical hernias, but incarceration or strangulation is very rare in children. Now, I should define those. So what is reducible? What is incarceration? What is strangulation? Well, reducible means that you have the squishy belly button. You can reduce the contents of that hernia. You can push the bowel or the omentum back in without any trouble, okay? Incarceration means that it's stuck. Either the bowel or the omentum or whatever tissue or organ is protruded through the hernia you're unable to reduce it, okay? Now, what is strangulated? That means that the tissue or organ is incarcerated, but now it's lost its blood supply and it's starting to die. And in that case, that can be a surgical emergency, okay? Why? Because that dying bowel can now perforate and lead to sepsis and septic shock, okay? So that is extremely rare in children, but it's important to know that that is something we need to watch for when we're observing an umbilical hernia. And so how do we treat umbilical hernias? Well, the best treatment, okay, is time. Time will usually lead to this fascial defect closing, all right? So if I have a child that presents to my clinic that has an asymptomatic umbilical hernia and that child is 2 years old or 3 years old, I'll reassure the parents, right? Educate them about incarceration and strangulation, and hope that over the next few years until the child is 5, that hernia will close on its own and we won't need to perform an operation to close it. Now, is there anything that we can do to assist closure? Well, historically, we would tape the umbilicus down, or some people would put a quarter on the umbilicus and that would hold the hernia in and hope for closure. Well, that doesn't help, and in fact, it can even make it worse, as that tape can macerate the skin, and the quarter, heaven forbid, the child could eat the quarter, and then they might need a procedure to remove that from the esophagus. So let these umbilical hernias close on their own, and you can reassure families, educate them about strangulation, incarceration. That risk is low, but not zero. And knowing that, now we can talk about, well, what are the indications for surgery in fixing an umbilical hernia? Now, one thing I want to put out there is that everybody likes numbers. So what is the size of an umbilical hernia where it's less likely to close on its own? Well, if you have an umbilical hernia that is greater than 1.5 centimeters, that umbilical hernia is less likely to close on its own. While spontaneous closure of umbilical hernias with a size of greater than 1.5 centimeters is less likely, if that child still has an asymptomatic hernia or does not have a large proboscis, then I will offer that parent the ability to follow that until at least the age of 5 years old to give that a chance to close, okay? So let's get into the indications of fixing an umbilical hernia. Now, we talked a little bit about the emergent indications for fixing these. So if a umbilical hernia becomes incarcerated or strangulated, or if the bowel dies and there's a perforation, or even if there's evisceration of the bowel. So the bowel comes out through the skin of the umbilical hernia because that skin breaks down. We see that more commonly in somebody with liver failure who has a lot of ascites, an umbilical hernia that has that degenerating skin. So incarceration, perforation, strangulation, even evisceration are extremely rare events, but they are indications for an emergent operation. Well, how about elective operations? Well, the first indication is if we don't have spontaneous closure of that hernia by the age of 5 years. Now, there is literature to suggest that it might even continue to close up to age 11, but I do give families at the age of 5 years an option for surgery because this is very well tolerated by kids. The recurrence rate is low, and I can usually fix this with a primary closure, a sutured operation with no implantation of mesh. Now, what's another indication? Well, this is if you have a large proboscoid umbilical hernia with a significant amount of excess skin. Sometimes we could say these are trunk-like or look like an elephant trunk, and they can hang down quite significantly. And sometimes I will fix these a little bit earlier, say around the age of 2, if there is a lot of excess skin. And we'll talk about some strategies to get rid of that excess skin. I'll put some references, of course, in the description below. And then the third indication is if the hernia is symptomatic. So at any age, if the hernia is symptomatic, then that is an indication for repair. Now, parents will come in and the child may have some abdominal pain, but that pain is usually due to GI upset, maybe a viral gastroenteritis, or often it is due to constipation and not because of the hernia. And we suss that out in a good history and physical exam. But if the pain is directed right at the hernia and we believe that is symptomatic, then that is an indication for repair, even if it is earlier than 5 years of age. Now, one of the reasons that we don't repair hernias early, so for example, if I have a baby or a very young child that presents to my clinic, is that repairing these hernias at a younger age results in an increased recurrence rate, and we certainly don't want to have a child who needs a second operation for an umbilical hernia. Now, how is an umbilical hernia repair completed? Now, if we have a straightforward non-proboscoid umbilical hernia, the way that I like to fix this, and remember, I like to teach surgical operations like a story. So every story has a beginning, a middle, and an end. So the beginning is the setup. So the patient has general endotracheal intubation. Sometimes I will have the anesthesiologist perform a regional block, so I have really good analgesia for the umbilical hernia repair, okay? And I will begin by making a curvilinear incision in a skin crease just inferior to the umbilicus. I'll deepen this into the soft tissues, identify that umbilical stalk where the hernia is, and then circumferentially dissect around this with a hemostat. Okay, once I've completely encircled the umbilicus, I'll separate the umbilical skin from the hernia sac and usually put a couple of hemostats on the hernia sac so I can lift this up. I'll excise or discard the extra tissue. Often there is some weakness superiorly, okay, superior to the umbilicus, and I will excise this tissue so I can get a nice strong fascial closure. Once I'm happy with the defect size, I'll close this usually with interrupted ovicular suture on a UR6 needle. That gives me a really nice curved needle to get good bites of the fascia, and I'll close that primarily. I like to put all of the sutures in and then tie them all in one series of knots, okay? Then I cut all the sutures at the end. Finally, I'll tack down the umbilical skin to the umbilical closure with a 3/0 vicryl suture. I'll close any deep tissue defect with a 4/0 monocryl suture, usually on an RB1 needle. And then I'll close the skin, usually with a running 5/0 monocryl suture with no knots in it, and I'll apply Dermabond. Sometimes I will put a pressure dressing, usually some Adaptic with a Tegaderm over it, but often I'll just use Dermabond, okay? If I didn't do a regional blockade, I will use 0.25% Marcaine with no epinephrine in it. It's easy to dose, and this will usually give some nice post-operative analgesia or pain relief. Now, what is the post-op care? Now, you see this child having fun, flying a kite. Well, I don't have any activity restrictions, and I usually tell parents that it's safe to go and have your child do the activities that they're going to do as long as they feel comfortable doing it. Now, of course, if you're a parent watching this, make sure you talk with your surgeon about any activity restrictions. But usually, young children who have an umbilical hernia repair are up and playing with their siblings or with their friends within a day or so, okay? So I will tell parents, watch out for a little edema, swelling, even bruising around the umbilicus due to that dissection. There may be a small amount of drainage. Usually that's from the local anesthetic. And the umbilicus itself is going to be quite swollen. That could take several weeks to months to return to its final cosmetic appearance. Now let's go to ventral hernias. So we talked about what ventral hernias are. So it's a congenital defect in that midline fascia, okay? And usually that's preperitoneal fat that's poking through and creating that lump, all right? Now this is about 4% of all pediatric hernias, so not so common, but as a pediatric surgeon, I see them quite commonly, all right? And this will usually present as an asymptomatic bulge. Now up to 50% of kids may eventually become symptomatic, and that's because that preperitoneal fat that's squeezing through that little 1 millimeter hole it's incarcerated. It can even get strangulated, and that fat can cause pain, okay? So 50% of these or more can become symptomatic. They can also enlarge with time. And when we discover these, they're usually discovered around the age of 4, we recommend operation at the time of discovery. Now, I'll tell parents that they are safe to observe, but they may get bigger and they may become symptomatic. And if they persist into adulthood, they can get larger, become symptomatic, and now require a more complicated repair, perhaps even with a mesh or prosthetic. So while these can be safely observed, operation is indicated usually around the time of discovery or about 4 years. If I do see one in a baby or a very young child, I'll usually watch these until the child is around 4 or 5 years old so that I can do an operation that has a very low risk of recurrence. Now, how do we do the operation? There are different ways to do it. There have been shown laparoscopic ways so you can have a very little scarring, but I find a 1 centimeter incision directly over the defect, deepen this down to the fascia. You're gonna see a little piece of fat popping through. I'll dissect this out, excise that fat, and then close this defect, usually with a 3/0 vicryl, and then I'll close the deep tissue, and then again, a running 5/0 monocryl subcuticular without any knots. Cover that with some Dermabond, and we usually have a very nice cosmetic result. Now the post-op care, same for umbilical hernias, okay? The Dermabond is gonna fall off on its own, may have some edema, may have some bruising. I will tell parents, both in umbilical and ventral hernias, what to watch out for a surgical site infection. So erythema, drainage, tenderness. If they see those, I want them to call the office right away and return for a post-op visit. But in general, these children will have very smooth recovery and activity. I let children get back to activity as they feel comfortable. Okay, so today we covered a lot for a pretty straightforward diagnosis. Umbilical hernias, ventral hernias, the umbilicus, the embryology. I hope you enjoyed it. If you did, subscribe to the channel. That lets me know that I'm providing value and that you're enjoying these. Give it a like, share it with your friends, comment what's the one thing you took away. If you want to visit CITIZENSURGEON.com, you can read the show notes accompanying this video, get the 4 important takeaways. And if you like that, definitely let me know because I do want to build out that free content for you. All right, like always, study hard, stay safe. I'll see you next time.